And then there are lots of new exciting drugs that we saw. This drug called camizestrant, which is another oral SERD. They compared it head to head to fulvestrant, and it did do better overall in all comer patients as well as in patients with ESR1 mutations. This was just a randomized phase 2, so we will need confirmatory data. So there are now several trials ongoing with camizestrant, which is exciting to see. There was also another new agent that I think looks very exciting called capivasertib, which is an oral AKT inhibitor. So what is that? When we can see in, for example, ER positive breast cancers, one potential mechanism of resistance is turning on this pathway, this PI3 kinase pathway, which then triggers AKT, mTOR, et cetera. And so the thought is if you could shut down this pathway, in addition to shutting down the ER signaling pathway, maybe we'll do much better than just the endocrine treatment alone. And that's what this study looked to address, is randomizing people to fulvestrant with or without this oral drug capivasertib. And it turns out about 40% of patients will have some alteration in this PI3 kinase pathway, whether it's a PI3 kinase mutation, AKT mutation, PTEN alteration. It is about 40% of people. And when you looked at all patients, irrespective of their genomics, you can see that people who got both drugs, fulvestrant and capivasertib, had their cancer controlled longer. And then when you specifically looked at those people who had a PI3 kinase pathway alteration, the benefit was even larger. So, I think this is pretty exciting to see, because it does suggest there's another potential oral drug that does seem to improve outcomes. And so we are hoping to see an approval for capivasertib, hopefully in 2023, and that could make this a standard option, where I think I would position it in people who've already had a CDK4/6 inhibitor, where you're looking to give them treatment at time of progression. These drugs do have side effects. I did just want to point out that the major side effect with capivasertib is it does cause diarrhea. It can also increase blood sugars, which is important to realize. So it is a lot less than with what we've typically seen with other PI3 kinase inhibitors like alpelisib. There is certainly less in the way of hyperglycemia and rash. So, it may be an alternative strategy here for patients with these genomic alterations. So I think we could shift gears, because there was also a lot of data presented with the antibody drug conjugates. Specifically, this drug is trastuzumab deruxtecan, which is a drug that's targeting HER2. So we saw data for HER2 positive metastatic disease, where they compared this.
And maybe at this stage, because we got a question, what is an antibody drug conjugate?
Yeah, good question. So basically, it's a fancy way of delivering chemo. So it's a targeted delivery of chemotherapy. And the way I think of it is, in this case, if you're looking at a HER2 positive breast cancer, it has HER2 on the surface. If the antibody is targeting HER2, that antibody is linked to chemotherapy. So when the antibody hits the receptor, it gets taken into the cancer cell and releases its chemotherapy into the cancer cell. And so a very clever way to deliver a lot of chemo into a cancer cell in a targeted manner. So we can get a lot more chemotherapy delivered than we could if we were not giving it in combination with an antibody, because then the chemotherapy is more free floating and would result in a lot more toxicity if you gave such a high concentration of chemotherapy. So I think of it as a clever way to deliver chemo in a targeted manner. And in this case, it's taking advantage of the fact that HER2 positive cancers have a HER2 protein on the cancer cell surface that they can target. And so in this case, trastuzumab deruxtecan is an antibody drug conjugate targeting HER2, delivering very potent chemo with it. And what they saw is when they compared it to standard chemotherapy and trastuzumab, it did a lot better. So you can see that the standard arm had their cancer controlled for about 7 months, compared to almost 18 months with the trastuzumab deruxtecan. So very dramatic differences. And you can also see that patients were living longer. So it was also improving survival. The catch with this drug is it does have a risk of what we call interstitial lung disease, or ILD, which is inflammation in the lungs resulting from this drug. Most of the time it's low-grade inflammation, so either patient has no symptoms and we pick it up on a scan, or patient does have symptoms and they do get short of breath, for example, and then we realize it. So it is important to let people know that if they are getting this drug, they do have to be very careful to look out for symptoms like shortness of breath, cough, and to report it right away, because we do want to stop the drug if that's the case and get people started on steroids. If they're symptomatic, we do not usually re-expose them to the drug because we are worried about resulting in more serious side effects, because there have been a couple deaths reported due to this toxicity. You can see 2 deaths here due to the interstitial lung disease. So again, a toxicity we are concerned about. It is rare, but we do have to be cautious. And then these were data comparing TDXD head-to-head with TDM1 in people who were really getting treated mostly in the second line for their metastatic HER2-positive cancer, with really a landslide difference, with TDXD doing much better than TDM1, with cancer controlled for about 30 months with TDXD, which is really impressive. So 4 times as long as a TDM1. And these data from San Antonio also showed that patients are living longer. And again, this risk of interstitial lung disease that we have to be aware of. So those were the highlights that I had put together, and I'm really